In today's lecture, I'd like to talk about genetic testing. I want to talk to you about three things. So I want to talk about the goals of genetic testing, the types of tests available, and then exactly how genetic tests are performed. Okay, so what are the goals? Well, the goals are basically different for different people, but here are some general goals. First, when we have genetic testing, we want to recognize the potential for a genetic condition at an early stage. The key here is this early stage. The assumption is that the earlier you figure out something, the earlier you can treat it, right? And the more successful that treatment will be. The second goal is allow people to make informed choices, right, about reproduction, informed choices. The third goal is to allow early intervention, right, to either prevent or lessen the development of a given condition. And then the fourth could be to alleviate anxiety if there is a known risk. If someone know that they have a family history of breast cancer, but they find out they don't carry that variant of the gene, that might, give them some relief. Now, on the other hand, obviously, if they find out they do carry that variant, that could give them relief in the sense that they know, or it could create extreme anxiety. So this is really highly specific to the individual. There's two types of genetic testing. There's prenatal and there's postnatal. We're going to talk about both of those today. Okay, these are some different abnormalities in which genetic tests are available for today, and it tells you what type of detection is used to test for these abnormalities. You don't have to memorize this list. I just wanted to show it to you to give you sort of a flavor for what's available today. Okay, so let's walk ourselves through a pregnancy. We're going to focus on the prenatal tests, right? And prenatal is everything before the child is born. And so the first thing that happens in a pregnancy is obviously if a woman finds out that she's pregnant, is about 8 weeks into the pregnancy, she'll go into her physician, they'll do an ultrasound. This is not an ultrasound at 8 weeks, this is much later, it's probably 20 weeks, but at 8 weeks what they do is they go in, and ultrasound is basically higher frequency sound waves, very benign, not dangerous for the child, because sound waves themselves are very low frequency. And what happens is it allows visualization of the organism or of the offspring when the waves encounter dense tissue and they bounce back. So again, this is about 20 weeks. This is not 8 weeks, but at 8 weeks you have a little blob. It would look almost something like this or something. But you could see the organism and tell if the child implanted correctly. You could also measure the size even at 8 weeks. So pretend there's a little blob here. You could measure the size. If the woman doesn't know the date of conception necessarily for sure, then the ultrasound is the next best thing in terms of discovering the due date for the child. And the due date is very important. You want to know that due date. If the date of conception is known, then it's very easy to determine that about 40 weeks later. But you want to know the due date. And the reason you do is because if children are born too early or too late, there's increased risks of many abnormalities or problems that could occur. And so you want the child to be born as close to the due date as possible, plus or minus a week. Later on in the pregnancy, about 20 weeks, you can ultrasound something like this, right? At this stage, you can actually literally see the head, or you can see the eyes, you can see the nose, you can see the mouth, you can see the spinal cord. And what they're really doing is measuring these dimensions, making sure everything looks normal. They're seeing the position of the child, because later on they want the child to come out head first. This would be early at 20 weeks, but they want to make sure the position's starting to look okay. And then they want to check to make sure the child has all its major organs, right? So it's a major screening. Pretty much everyone does ultrasound because it's very low risk, and there's a lot of good information that can be gained from the ultrasound. There's other tests available too, and this is a test about just before the 20-week ultrasound, maybe like 16 to 18 weeks or so, and this is something called amniocentesis. It's not something that most people do, though many people do it. And it's a test basically where a syringe is inserted through the mother's abdomen, and they withdraw some of the amniotic fluid. And this amniotic fluid contains some fetal cells, right, that have sloughed off the fetus. These cells can be cultured in a dish, and then after a week or two, after you culture them and grow up a certain critical mass of cells, you can do chemical analyses, DNA analyses, chromosomal analyses, check for many different types of abnormalities that could possibly be present in the child. Now there is a risk with this test, right? It's a low risk, but there's a risk, about 1 in 400 miscarriages. So someone has to really think, what are they going to do with this information? Would a given result cause them to act differently than if everything was okay? Would it relieve anxiety? Would it not? So you really have to think about what you would do with the information of this test if you decided to do something like this. Though, like I said, most people don't do it, but it is something that is, fairly common in the sense that many people do it. Another type of test that's available even earlier, and this is much more rare, really you'd only test with this if the physician felt there was a major concern, but something called chorionic villus sampling. And this is done earlier, like around 10 weeks or so. And there's a catheter that's inserted into the female, and what happens is they basically take part of the chorion, right, which is the outer layer of the placenta. They take that, they remove that, they get a very high density of cells. Since they got such a high density, they don't have to culture the cells, and they can immediately go to these chemical tests, DNA analyses, chromosomal analyses, the same things that were mentioned on the previous slide. And they can get the same information, but much, much quicker, and allowing the couple to make a more informed decision earlier in the pregnancy when the risk is lower if a couple did decide to terminate the pregnancy. Okay. Whenever we talk about chromosomal analyses, really what we're looking at is a karyotype like this. And so this is the information that you can get either through amniocentesis or chorionic villus sampling. And what you're getting is you're saying, are there the right number of pairs of chromosomes? You could determine the sex of the organism too. And you could also determine the sex with a fair amount of certainty through ultrasound. And really they're looking to see are there the correct number of chromosomes. There's other types of tests that are done as well, right? So there's things called maternal blood tests, where they look for the presence of, this is just one example of something called alpha-fetoprotein. It's normally produced by the fetus, but if there's high levels, it could indicate a neural tube defect. If there's low levels, it could indicate chromosomal abnormalities. With these types of tests, really, it's not necessarily a yes or no answer. It's more like a percentage. So again, you got to think, how would you interpret that if you did it? What's the benefit to you as a couple, to your child, and then honestly, what's the benefit to the physician in terms of would it help them, help you navigate the pregnancy in any degree? There's also non-invasive fetal diagnosis. Once you get those fetal cells, you can actually sort them using cell sorting machines. So something like a flow cytometer, where it shoots cells through a column one at a time, and then a laser hits the cell and basically tells you about the physical characteristics of that cell, whether it has any abnormalities or not. There's also something called pre-implantation genetic diagnosis. This is something available through in vitro. And what this is as we learned at the earlier lecture, right, the 8-cell stage is the morula. So once you're around that stage, what they can do is they can pluck one of the cells off. Again, this is done in a test tube, right, before the embryo is implanted into the woman, and they can say, what's the gender of that child? Are there any known abnormal issues with that child? And the couple can make an informed decision about whether or not they want that embryo implanted or they don't, right? And so that's something, again, that's available. All of these tests, I'm not suggesting they're tests that you should or should not do, when the time comes, but they're tests that are available and things that you want to think about. Okay, so let's talk about some postnatal tests. So some postnatal tests, some of them are just standard, right, and some of them are sort of optional. When the newborn is born, there's some newborn screening tests that basically the hospitals just do. I'm sure you have to sign off on them. I'm sure someone could refuse. I think they could. I'm not positive, actually. But they're very non-invasive, and they give you information that you can really do something with. In other words, things that can be, for lack of a better word, fixed, right? And so what I mean is, for example, there's this PKU test where it's an autosomal recessive genetic disorder. If someone has this, they have a deficiency in the hepatic enzyme or the liver enzyme that processes phenylalanine, right, one of the amino acids. And the reason you want to know this is because if someone's given a diet that's high in that amino acid and they have this disorder, over time they're going to develop severe mental retardation resulting from that. However, if you fix their diet and perhaps give them, some therapy in terms of injecting the enzyme into them, depends on how severe the case is, but that child can grow up completely normal. So you can see this is something that you really would want to know because it's not invasive, and just simply changing a diet could mean the difference between having a normal phenotype or having mental issues. And so that's one example. And here's another example here too that you could read about. So these newborn screens are pretty standard. There's something else called heterozygote screening. This is done before a couple has a child. So if two people meet, this isn't going to sound too romantic, right? But if two people meet and they are of the same ethnicity, same geographic area, same race perhaps, it depends, what the couple thinks. But remember, if they're similar, they're more at risk genetically of both being heterozygotes for a given defect. And so there's certain defects that are known in certain populations. A classic example is a defect called Tay-Sachs. that's very highly present, relatively speaking, obviously, in Eastern European Jewish populations. There's something called thalassemia. That's a defect that's very prevalent in Mediterranean populations. Obviously, there's sickle cell anemia with certain African populations. And so every ethnicity, every race has its thing, right? Its disorder that it could be prone to. Heterozygote screening is just identifying and saying, are we both heterozygotes for the same thing? If we are, and it's autosomal recessive, right, then we have a 25% chance of passing it on to our children. And even though neither one of us expressed it. So that's something you have to think about. What would you do with that information, right? What would you do with that information? You could decide we're going to have children anyway and just, see what happens. We could decide to do in vitro fertilization, right, and do that pre-implantation analysis. Or we could decide not to have children, right? Or we could decide not to stay together as a couple. I'm not suggesting any of those are preferable options. I'm just saying those are the options that are available. So some people do heterozygote screening if they're close genetically. By close, I just mean same ethnicity, same geographical area, and they want to know that information. That's something that's available. There's also presymptomatic testing. Individuals that are totally healthy at the current time might have a family history or know that they are prone to certain types of breast cancer, for example, caused by the BRCA gene, or they might know there's a family history of Huntington's disease. And so before they even develop the disease, they might test to see, do they have it? Are they prone to it? It's not a yes or no answer sometimes, but are they prone to it? And if they are, sometimes they take, maybe dramatic action to prevent that. There's been many examples in the news recently. Angelina Jolie, Christina Applegate are women that have decided to have complete mastectomies because they tested positive for one of the genes that increases your risk dramatically for breast cancer. Again, not suggesting someone should decide one path versus the other. Just saying these are the types of tests that are at your disposal, and these are some decisions that some famous people have made that we know of. Okay, so in this lecture we talked about the goals of genetic testing. Remember, that could be different for everyone, right? The types of tests that are available, and then how the tests are performed.